introduce her and then let you take it away, Dr. Law. And forgive me if I have to pause. I'm kind of balancing admitting folks and reading the introduction at the same time. So please bear with me here. But we have with us today Dr. Anandi Law. She's a professor in the Department of Pharmacy Practice and Administration at Western University of Health Sciences at their College of Pharmacy, as well as being Associate Dean for Assessment and Director of ACCP's Peer-Reviewed Fellowship in Health Outcomes. So we're excited to have her today to share her talk, as you can see on the screen, Changing Winds in the Profession, A Time for Transformation. As a way of background, to give you a little bit more context, Dr. Law is an associate professor and completed her B.Pharm degree at the University of Bombay in Mumbai, India, her master's degree at the Ohio State University, and her Ph.D. at the same. Her research interests are improving medication use outcomes for patients using pharmacist interventions, development and validation of patient-reported outcome measures, educational assessment and outcomes, and leadership, self-awareness, grit, and the growth mindset in student pharmacists. Her focus is on disseminating information to the profession, the healthcare community at large, and policymakers via publications and professional networks. These areas of interest are a synergy of her training in health outcomes and her background as a pharmacist. And in addition to these, she's active in professional associations such as APHA, AACP, and ISPOR, and she also serves on the editorial advisory boards of 4 peer-reviewed journals. So clearly she has lots of free time, and we're really appreciative of her being here today. I do want to mention that we're going to show the CE code at the end. She's got it on her slides at the end. So you can ask me for it, but it'll just be easier if you wait till the end, and I'll drop it in the chat if you miss it then. And if you have any questions during her presentation, feel free to drop those in the chat as well, and I'll be monitoring that. So yes, take it away, Dr. Law. Thank you so much for being here.
Thank you, Madeline, for all your help with the presentation, and Dr. Salgado for inviting me. It's good to see you all, and feel free to eat your lunch as you're listening to me, because I know this is lunchtime. It's breakfast time for me in California. So I'm going to spend a little bit of time today talking about what's going on in the profession. And as most of you are within it and have, your backgrounds in pharmacy, you may, relate and be able to respond to some of the questions or some of the, kind of the things I throw out at you. And feel free, if you have any questions, to put it in the chat, because I can monitor it right now. Okay. So the title of my talk is Changing Winds in the Profession, A Time for Transformation. So why did I come up with this? Well, let's look at some of the discussion objectives. We're defining current issues in pharmacy, discussing the possible causes for those issues, illustrating the relationships within the healthcare system. And I'm just going to go from, assuming that, some of you have some background, but I'm just going to go ahead and look at all the relationships. Describing the reimbursement process, and then looking at the history of PBMs and their role today, the impact on pharmacies and the profession, and then looking at some possible solutions. So anyone put in the chat, what is currently happening in the pharmacy world right now? Maybe a couple quick responses. You can shout it out or put it in the chat. Either way is fine. Anyone? Chaos. Push for increased pricing transparency. Very good. Pharmacies being ripped off. Excellent. Expanding. Scope of practice expansion. People are doing different things. Wonderful. So all great responses and all correct responses, of course, all of the above. So what we are also noticing, part of that chaos which was mentioned, and the pharmacies being ripped off, is community pharmacies are closing across the country. And in California, we have about 4,800 community pharmacies. We've seen 1 in 6 close in the last 4 years, and nationally it's about 1 in 8 is the number. So what's the long-term impact of these pharmacies closing? Well, we're talking about independent pharmacies, right? A lot of them. And drugchannels.com CEO and futurist Adam Fine said in another 5 years, we're going to see about 10 to 15,000 pharmacies close across the country. And so 50% of pharmacies are going to survive, which means now 3 out of 6 are gone, right? So what happens if these are gone? And do we think this is only happening with are independents. Well, I have news for you. If you look at some of these are all copy paste or screenshots from news articles. Foodland is, a small chain in Honolulu, and it's closed its 7 pharmacies and sold it to Long Drugs. The decision to exit the pharmacy business was not an easy one for us, while compressed margins and rising costs have led to increasing losses. So they're talking about margins. Well, CVS, our biggest chain, closing 900 retail stores. I'm sure you all heard of that. And they have a new strategy to meet evolving consumer needs, includes closing stores and creating new store formats. Well, we have to read between the lines. I'm sure they're struggling with some of those profits in some of the stores. They're not able to make, prescriptions or profit margins. Drugstore chain Walgreens in California, they said we're going to, in San Francisco, they said we're closing 5 stores, and because they've had some thefts, and they said it's organized retail crime. But then the consumer group said, oh, are you closing because of theft or because of a pre-existing business plan to cut costs and increase profits? Because thefts is not a long-term thing, and it's a fixable solution. You can have more security. There are things which are possible. So this is happening across the country in both independents and chains. So there is something going on here. So why are these pharmacies closing? Well, some of the things which have been thrown out, and in the earlier slide, I forgot to mention, but here is an article. It's based on a blog from Dean Michael Hogue, who is past president of APHA and current dean of Loma Linda in California, Loma Linda University College of Pharmacy. And this is in the slide, so you can always take a look at it later. But he's mentioned a couple reasons, and there's enough in the evidence in the literature as well, that pharmacies are closing because of lack of payment for her services. Right, the product, the payment is aligned with product, so that's a big reason. And in the shift in the way drugs are paid for by insurance companies. And of course, the bottom line here is also that pharmacists are overqualified and underutilized, words which we've heard over and over again. So our reimbursements are going down. What is reimbursement and how does it work? So doing a quick background on this. This is got to be the messiest diagram you'll see. And this is what I present to my students, because they're like, oh, what's going on with healthcare? I'm like, okay, this is the web that is going on in healthcare. And we see several triads here, which I'll go over quick because I know most of you already know this. But we are facing, issues because there's just too many players in healthcare and everyone wants their piece of the pie. And it's justifiably so. But what happens when we have power equations within healthcare? So if you're a patient, you belong to a health plan, an HMO, PPO, POS, point of service, and you're a covered life of the health plan. You get your healthcare through your employer or CMS. And so now if you're a patient and you want to go see a physician for a healthcare issue, you're going to the physician. The physician, of course, has to have a contract with the health plan. And so physicians no longer have direct contracts because it's too painful. They all belong to IPAs, or independent provider agreements, which is an entity which is now contracting with the health plan and acting as the go-between so that they can negotiate terms and pay physicians based on a fee schedule. So now in comes the IPA. So physicians now belong to this IPA. So, okay, so you go to the physician gives you a prescription, which happens 70% of the time when you go to a physician's office, according to national stats. So you're taking this prescription and then of course you could have some labs done. The lab also has a contract with the health plan. Usually you don't have a copay for the lab, but for the physicians, you're having a copay and the rest comes from the IPA. The patient now presents the prescription to the pharmacy. The pharmacy, of course, needs to have a contract with the health plan. It used to be direct, but now most health plans go through our friend, the PBMs, the pharmacy benefit management companies, which have contracts with health plans, which could belong to the health plan or be outsourced as a private entity. Now, the health plan gives the PBM allocated dollars for managing claims. The PBM decides those terms for the pharmacy and says, this is how much you're going to get paid, AWP minus X% plus a dispensing fee. The pharmacy has to have a contract, and the pharmacy is under, basically the PBM's power. Now, a pharmacy is getting its product from the wholesalers, its reimbursement terms and payment from the pharmacy, from the PBM. The PBM has as you all know, the pharmaceutical industry has Now the PBM deciding what goes on formulary for the health plan. So the pharma industry is contracting with the PBMs for kickbacks, because every time a prescription is filled at the pharmacy, the PBM sees the claim, sends it back to to the pharmaceutical manufacturer, and they send a kickback, and we don't know how much those kickbacks are. They're not illegal, but we just don't know how much they are. The pharma industry, of course, provides product to the wholesalers, and then the FDA gets in because they're regulating the drug product, and CMS, of course, because they're both administering and funding um, the Medicare and Medicaid services. So we have all these things going on. The key part here, and of course, I forgot to mention that, of course, if you need healthcare in a hospital, the hospitals, which are the most expensive part of the healthcare system, also have, contract with the health plan. But now the health plan is, this basic conglomerate, which has everyone contracted in the supply chain. The policymakers, of course, have relationships with everyone. I didn't put, 20 different arrows, but they have relationships with everyone, with SIGs and with lobbying groups. So this is our wonderful, messy healthcare system, and it works well for the most, but of course we have our problems. So the reason I brought this up is because, and this is a cleaner diagram from Drug Channels Institute, is if you look at the different ways our products flow one way, the information flows another way, money flows a different way, and so we have all these different things going on. So there's just so much going on that there is not a coordinated system, right? And of course, because we are in free market, they probably universal health coverage. We don't know if it'll ever come. California just shot it down the second or final time. I don't know if it's ever going to come back. But this is all that's going on. So in effect, pharmacies and pharmacists don't have much power in the equation because they're being controlled by everyone else. So that's kind of the root cause of thing. So what is PBM? In the 1960s, all they did was manage data. They were large data warehouses, and they slowly began adjudicating prescription claims over time just because they had access to this database. In the 1980s, when managed care made its headway into healthcare, they started collaborating with pharma industry and managing formulary on behalf of health insurers. Now, they have one of the most powerful positions in the healthcare and pharmacy field, where they negotiate drug prices and rebates with pharma. They determine the reimbursement rate for community pharmacies, manage data to give health insurers recommendations and pipelines, and they impact prior authorization. So how the money flows, we've seen. Now, as opposed to the patient being in the center of this equation, we are seeing the PBM be in the center of this equation now, where the data, they control some of the data, the reimbursement, the information flow, kickbacks. So it's kind of they have a very powerful role in this equation. And in come this whole concept of DIR, direct indirect remuneration. So what happens with direct indirect remuneration? And let's take a look at that. So PBMs have come under scrutiny for not paying pharmacies what the PBM is billing Medicaid for drug acquisition costs. PBMs use clawbacks. So this is what happens. The pharmacy buys drug through the wholesaler for about $85 as an example. The pharmacy then submits, dispenses the product and submits a claim to the PBM for $100 based on benchmark price and based on the terms of reimbursement, markup, all of that. So that's $100, which is a pre-agreed price. The PBM adjudicates the claim, sends the pharmacy $100. Pharmacy has a gross profit of $15. All's well, fine. But now with this clawback and the DIR, months later, the PBM claws back a $7 DIR fee from the pharmacy, saying for very many different reasons, which we can look at later, cutting the pharmacy's gross profits by about 50%. So these clawbacks are DIRs, and they were actually made for a different reason. The idea was to pass along savings from the PBM or Plan D sponsor to Medicare, which would then pass it on to our patients. That did not happen. We have retroactive fees. We do not have any transparency in this whole DIR model. And the calculation now is based supposedly on pharmacy performance metrics, which are loosely defined and not very easy to meet. And there is nearly no accountability. Of course, it's not that the pharmacy world is kept quiet. There are lawsuits. Arkansas, there are many states which have lawsuits against PBMs. We have a national level issue. We have tried to moderate that in California as well. So things are happening on that PBM side. So in effect, what happens with this DIR is if this is the AWP minus X% plus dispensing fee, which is the term of reimbursement decided between the PBM and the pharmacy, part of it is taken away. And mind you, this part of the profit, which is taken away by DIR, is already spent by the pharmacy for their operations, right? It's not like pharmacies are sitting on a hot bunch of cash and saying, oh, we're rich. This is an operation which requires fluid cash and they're constantly going through it. So the pharmacies are closing because they just cannot sustain with all these different measures. DIR is only one. There are other PBM strategies, setting copays higher than the cost of drug in many cases. So, that the money comes back to them. So because of copays, instead of patients just paying out of pocket. 3 PBMs right now, if it's not evidence enough, control 80% of the prescription market. And those are CVS, United Health, and Cigna. They rank in the top 20 on Fortune 500, ahead of pharmacy companies, ahead of tech. So we're really talking a lot of power. Right? They're receiving kickbacks from drug manufacturers, which is fine, but we don't know the amount of kickbacks and we don't know what are the conversations. And in addition, in terms of the DIR, many PBMs have gagged pharmacists so they cannot discuss less expensive alternatives or even lower out of pockets for not using insurance with their patients, because you have the various clauses in the contract between the pharmacy and the PBM, which says you cannot talk to the patient about any cheaper options. So in effect, the PBM hedges in prescription, gag clauses, DIR. So pharmacy is being kind of, crushed from all directions. And that's why we're seeing them close. In addition, if there was another model of revenue generation or compensation for pharmacists, which includes being paid for services, that has not happened, right, with provider status. So we are facing several changing winds, and the profession has to figure out what to do about it. So we all know that, this is just the equation which says the revenue coming to the pharmacy is only through product reimbursement and dispensing fee. And the pharmacy has to manage that, their acquisition cost and cost of dispensing, which includes inventory or merchandise, payroll, which is a huge expense next to inventory, and overheads. And what is left behind is the profit. So as the revenue stream keeps decreasing with DIRs, with reimbursement terms, pharmacies have to manage everything, and payroll does not decrease. We cannot pay pharmacists less. Also, although we have seen that model too, the profit margins keep getting less. So the impact on community pharmacy, as we already see, is with lowered reimbursement, is they're not able to hire as many people, as many pharmacists and techs. So job opportunities go down. There's more prescription volume per pharmacist and per tech. So there's difficulty maintaining profitability, because it's kind of a domino effect. As you hire less people, you can fill less prescriptions, and then your profit margin keeps going down. So it just keeps circling. And with COVID, of course, we cannot forget that pharmacies were open throughout the pandemic. We know that. But they had increased workload with testing and vaccinations, which is great in terms of expanded services. But then are they being paid more? There is a lot of burnout. We know that's a hot topic right now. APHA is discussing it. We're discussing it across the nation in terms of the level of burnout of our pharmacists being asked to do a lot more for same or slightly higher pay. And we are seeing kind of a bimodal thing in California here. We're seeing, and it may be true in Virginia too, but we are seeing on one hand, our graduates being offered $50,000 bonuses for working in rural areas. But in the saturated Orange County area where there are no more jobs, then pharmacists are not getting jobs. So, we are incentivizing our graduates to move into rural areas, but that's happening too. But even our students are on rotation are being asked to do a lot more. What is the impact of this on our patients, who are our life force? Well, there are fewer pharmacy options if these pharmacies close, less accessibility to medications, and it's not like our number of prescriptions, chronic conditions are reducing any day, right? And less interaction with pharmacists, so possibly more medication misadventures. We have what we call pharmacy deserts, where you have populations which don't have access to a pharmacy. And this is strange because nationally, all of us live within 5 miles of a pharmacy, right? But as these pharmacies close, those miles start increasing. So now if we have pharmacy deserts, patients don't take their medications as they should, they cannot access their medications, we have more provider visits. We have more visits going back to the physician because your numbers are not looking good. Your adherence levels are not high. So you have higher burden on the primary care physician. And we already know there's a primary care physician shortage in this country. This is from all the data which is going on, which talks about 1 in 3 neighborhoods in large US cities are pharmacy deserts, according to one study. Pharmacy deserts may limit COVID-19 vaccine access in communities of color. This is happening. University of California and Irvine study first linked disparities in pharmacy deserts in California. So the impact of these pharmacy deserts where you don't have pharmacies is unfortunately in areas where there is need, there is social, disparities, and patients need access to pharmacists. Sometimes they use them as the access point into healthcare. They use them for getting their meds. They're in low income areas, and if these disappear, we are seeing more issues with healthcare for our low income patients. So do we have too many pharmacists? That's the other question. Well, can we, do we have too many pharmacists? So we are bursting with pharmacists when the pharmacies are going away. And the answer is no. If you look at the national stats, we have 315,000 practicing pharmacists serving roughly, and I just made that, closer to 315, it's probably 320, 315 million Americans. So we're looking at one pharmacist for about 1,000 patients, right? Which is a lot of volume, given that in the adult US population, more than 50%, about 51% are taking at least one chronic medication daily, right? And those numbers are only going to increase. And we have a mental health epidemic as well in the country. We have 209,000 primary care physicians. There's a shortage there. And about 419,000 pharmacy techs, right? So these are the people kind of the front end who are working with prescriptions and with medications. And so we see that we don't have enough pharmacists really to serve our population. And yet we keep talking about too many pharmacy schools, too many pharmacists. But the truth of the matter is it's not being channelized properly, right? We may have too many pharmacists because we don't have enough pharmacies now to employ them. And we don't have pharmacists providing the roles they should be, which is clinical services, managing meds, not just, transferring the drug from the wholesaler to the patient, right? We have a much bigger responsibility, which we're not being paid for. So we really need transformation within the profession. Coming back to our impact of closing pharmacies on hospitals. So if patients don't take their meds, it gets more complicated, the more admitted patients, there's an increased workflow within the hospital, increased patients' wait time. We saw that in LA and in Southern Cal, and we kind of moved away, and now we're coming back to that. More ER visits, longer waiting times, more transitions of care, prioritizing or triaging patients. In AmCare, I put a star there because perhaps this is, we need some chaos before the revolution. There is going to be an increased need for pharmacists managing patients. If the primary care physician shortage, we need pharmacists to provide that interaction in terms of managing the meds, right? We already saw at AACP that, Todd Sorensen put in that bold claim about having pharmacists within physician offices. We need models, we need experiments to really show that this is working, right? We know we have more than 30 years of data to show that pharmacists provide clinical services, pharmacists as part of the healthcare team really helps improve health outcomes, reduce costs. We don't need any more data on that. But right now, probably we need some demonstration projects, some models of where pharmacists within physician offices are showing how well this can be done. And this is happening. It's not that it's not. What is the impact on student pharmacists as pharmacies close? Our community rotation sites go down, community pharmacy jobs are lower, and we are already seeing it in California and across the country. As placements decrease, that impact is felt at the applicant pool end. And nationally, we're seeing a dip of applicant pool, and it's slowly progressing. This year is about 5%, but across few years, it's been close to 25%. So we're seeing a decrease in interest in pharmacy as a profession. And for those who are are within the profession, if they don't get jobs, there's increased difficulty in paying off their student loans. So the impact is felt all over. And finally, the impact on academia, as I said, applicant pool goes down, rotation sites for pharmacy, the quality rotation sites go down. And as the number of pool goes down, the applicant pool goes down, we also see that we go lower and lower on our waiting list, which means the quality of students may decrease. We're having progression issues across the country, NAPLEX pass rates. So some of that also could impact. And if the NAPLEX pass rates go down, again, the public sees that and like, oh, we don't know if we should be entering the school. So there's all over an impact on the whole profession. And a shift in community pharmacy roles is what we need, right? To kind of wrap it up. So we have the dispensing roles in mail order and specialty pharmacies and in community pharmacies. So we may see more shift to mail order, which is okay if pharmacists are being asked to do more counseling. And just like in any other healthcare profession, not all pharmacists may want to do this, right? It's not like we need to be away from the product. I mean, we have the VA model, we have the Kaiser model, where pharmacists can both dispense or have a central fill, and then the patient is receiving counseling. And that model of product plus services would be excellent, because now you show the patient the medication, take them through the label, help them understand, and they walk away with the product. They associate us with it, but they also know all the medication information we've given them with it. I mean, that would be the ideal model. So we hope we see more counseling through telehealth. And at Western U, I just started a call center, which has been in several other places like Arizona, Florida, and other like Creighton. So and maybe VCU has one too, where we are actually now contracting with health plans to provide their high-risk patients adherence counseling, CMRs. So our students are involved in the telehealth calls, and so we train our students, and the students conduct the calls, and we have faculty members and alum who sign off on these calls. And we are slowly working on improving adherence, and it's a financial accountability model for us, which means the patients reach outcomes that helps with the accountability and with the revenue stream. So those are some things happening. MTM, as we know, in California, Medi-Cal has said that they will pay pharmacies and pharmacists for MTM through Medi-Cal, which is Medicaid in California, and that goes with the provider status we have in California. So that just happened this year. Transitions of care, which we are already seeing this across the country in terms of the Medicare 5-star ratings, and hospitals reaching out to schools of pharmacy saying, help us with transitions of care. And clinical visits, where we can focus on pharmacists providing clinical visits. So hopefully we'll see some of this shift. There are some other scenarios that we came up with, and this is part of an article we published in Pharmacy, the journal Pharmacy, where we presented some other scenarios for the profession to continue our growth and change into clinical services. So one scenario is where the pharmacist creates the PBM. So we create pharmacies create PBMs, and this model actually we are seeing it in California with several of our companies. One of our alums has established a company. We're seeing it with GoodRx. We're seeing it with several of these places where it's direct to consumer. And the pros of this is that's transparency, so patients know what they're paying for. Pharmacies are able to control the flow, monetary flow, and so are patients, and they're able to self-regulate. The con is, of course, that small retails need to network. So we need to have community pharmacies come together and have a pharmacist run PBM, or some kind of model of PBM where the burden is on pharmacists. But that means our workflow increases, and we have to build bargaining power for this. Scenario number 2 is to do away with the PBMs and have a transparency uh, prescription model where patients are able to shop, right? Just like we shop for, we go on, we go shop for any kind of thing, and you have um, like on like a whole server telling us on a server, like a whole search engine pulls up all the possible companies, and then we can do price shopping. If we can do that for pharmacies and for medications, patient can price shop for those meds. There's transparency, it's cheaper drugs by price for the patients. It helps the whole system kind of get a little tighter on price controls. And there's an increased trust between the pharmacists and PCPs, because we are not, we are not only providing expensive drugs, and the patients are able to shop for it themselves. They can either use their insurance and pay copay or pay cash. The con of this is, high cost medications. We know our hep C drugs, we know our COVID drugs, they're expensive. We have, so who manages that? Who pays for that? And how does insurance work for that? And the burden of responsibility on the relation between pharmacists and PCPs. So we are still hoping interprofessional care and that there's communication. And this is, just based on what I just said. So patients now are able to make the decision of what they want to do. Scenario number 3 is what I mentioned before, clinical pharmacists at the PCP office. So dispensing function is separate. There's direct cooperation between the primary care provider and the pharmacist that helps interprofessional care, as well as get the best possible medications to our patients, most cost effective. And there's comprehensive care for our patients, because we see them, pharmacists see them within the office. The con is dispensing for acute conditions has to still be, figured out. But this is probably the one model which has the least number of cons. Scenario number 4 is something we are presenting, and we're looking to test this model. It's what we call is a shared risk value-based payment. And we also call it an accountable care organization with pharmacists and patients. So we all know that there are several examples existing across the country where, and in California, it's called the Right Meds Collaborative, where pharmacists and physicians work together to manage a risk group of patients, like an accountable care organization. And the payment which is made is based on services, and it's provided to the physician, and then the physician also provides part of it to the pharmacist, and it's based on a value-based payment. So if the patient is improving, you get an additional bonus from the health plan. So what our model is to, and all these models are wonderful and they work, but they're also based on patients taking the meds as prescribed, right? So that becomes kind of the rate limiting step. And we've seen many models where the physicians do their best job, the pharmacists are doing their monitoring and the best job, but the adherence rate with patients and them taking their meds as prescribed, persistence and adherence both are not as sustainable. So they start, but then they start dropping off. As we know, that's a continuous issue. So our model includes the patient's accountability and including some shared responsibility for patients, where the patient is part of this accountable care model now. And that way, the pharmacist, patient, and physician are all working together in the triad. The physician is managing, of course, the overall healthcare or overall patient numbers, the pharmacist monitoring and counseling, and the patient also has a risk reward model. The con of this model has been, of course, the buy-in. And in California, we've noticed that health plans are very skittish when we go to them and talk to them about a risk model. Like, we cannot touch, the risk model in Medicare or Medicaid. So we're trying with commercial models where patients, so the way it works is kind of like the Aspen model, if you're familiar with it, which is patients receive an incentive for continuing to maintain their numbers. And if they don't meet the pharmacist or they don't follow up, then there is a risk, right? So the risk part is what we are not able to manage, because health plans, they see it as a liability issue, and they, there is issues with member engagement there. But we're trying only the incentive part. And there are some health plans which have tried it Blue Shield has tried it on a very small scale with providing Fitbits to their patients, but they haven't held them accountable. So there's the accountability one. So this is a model which we'd really like to test nationally. So if anybody is interested in working with us, we would love to test this model. Scenario number 5 is another model we're trying to set up, and we had set up a little in California, but it fell apart. So we're trying to do this again, which is set up a pharmacist network. We all know about 1-800 dentists. So we're looking at kind of a similar model where patients get their meds, mail order, which is, we cannot stop e-commerce right now with everyone getting into the act. And with COVID, we all got used to just getting everything delivered at home. I don't think that trend is going to stop. But we still need that patient pharmacist interaction, as we know, for adherence, which is, our $300 to $500 billion problem in the country. So the idea is to have a pharmacist network where patients may get the drug, but then they can just pick up the phone and talk and call a pharmacist. And the pharmacist is available to provide medication related information to the patient, and just how to take it, when to take it across telehealth platforms. And this is something which we'd like to explore. And this is hopefully one of the things we are moving into the future in terms of health anywhere or digital health. The con is, of course, the investment needed to build something like that. We are talking to our California Pharmacist Foundation in terms of a CPHA or California Pharmacists Association to see if there is a possibility of that. And of course, we'd have to spend some dollars in marketing. But this is another scenario we're thinking of where it helps us transition into clinical roles, or not just transition, and move more pharmacists into clinical roles, get away from the brunt of being paid for the product and pushing the product, and maintain that level of professional, so we are looking for reimbursement and recognition. So it addresses both of these. So what also needs to transform within the profession is, of course, the practice models, the payment models, but also attitudes. So we did a recent national survey. I'd done one about 20 years back at the beginning of almost at the beginning of my academic career, where we surveyed physicians, pharmacists, and patients to see how they perceive or how they view pharmacists in their roles, what kind of roles within the medication use process of prescribing, transcribing, administering, dispensing, and monitoring. And we said, what role do you see and who should be providing that role? So 20 years back, we found that pharmacists were mostly focused, patients thought pharmacists mostly focused for dispensing. They wanted, the drug quickly, like a fast food thing. And as we've seen that, physicians were more about, oh yeah, pharmacists should be in the pharmacy doing their thing. And pharmacists did see expanded roles. So we said, okay, 20 years from then, let's see, after interprofessional education, after collaborative practice models, what is happening with that same survey, very similar survey. So we asked patients, pharmacists, physicians, who's the best person within the medication use process at each step of the process? Why do, if there needs to be improvement, who do they think should step in or step up? And what are their reasons for those, for their answers? And what we found, and we've been presenting this at APHA, will do it across the several meetings. Patients see pharmacists now a little bit more for counseling and monitoring, which is great. And we have both quantitative and qualitative data, which we're planning to publish. Pharmacies see expanded roles, but they're limited by time, staffing, and reimbursement. Physicians see us helping, but and we only looked at primary care physicians, but many of them actually commented that pharmacists should kind of stay in their own lane. So there is still a lot of education needed here on collaborative practice. So we do need transformation within the profession. What will help the transformation? Branding and visibility, and we know that nationally. Adding services to product or separating services, as I mentioned. Allyship with healthcare professionals who endorse us. We're already seeing, based on the test and treat policy, which President Biden announced, we've seen AMA put out their policy and APHA pushing back, which is wonderful. But we need physicians to start speaking for us. And we do have physicians. Johns Hopkins just released a statement where they said, we can't be siloed. We really need everyone to work together in the healthcare system. Policy, we are pushing standard of care rather than scope of practice, which limits us by regulation. Standard of care model basically looks at us functioning at the highest level of our license. So we need to, also have a change in policy. Any other ideas? We're up for it. This is, my talk, but I'm absolutely open to ideas. And I think as a profession, we need to work together. So that kind of ends the presentation. And Madeline, so there's just about how can students can help, fundraising, educate people, etc. Because we know policy is made of notes and votes. So, organizations can help. Any questions at this point? I can address the questions and then, we can look at the CE code. So you have some time for questions. And Madeline, in terms of the CE questions themselves, is that something which is released later?
That was something I was going to pull up as a poll.
Okay.
Right now, if you want to do it now, or we could take questions first, whichever.
Let me take questions first, I think. Yeah.
Sounds good. So go ahead, everyone. If you have a question, you feel free to unmute and ask, or you can drop it in the chat.
What is your view on Amazon's pharmacy model? Great question. So, Amazon had Haven, right, which they started with JP Morgan and what's the other company? Warren Buffett's company, which I forgot now. They had started that, and they had hired, Atul Gawande as their CEO, and they wanted to recreate healthcare, and that Berkshire Hathaway, thank you. And that did not work. They actually shut it down last year, and now they're looking at, they did the pill pack, and they bought over pill pack. They're looking at other models. So from where we are looking at it, they're still only looking at mail order, right? They're looking at mail order pharmacy. And they're making it so they can go across states. We have some states who do have, barriers to interstate e-commerce. So they are dealing with that. But right now we still see, everybody's waiting to see what Amazon does. But I haven't heard anything, but and maybe there are other people here who are much more informed than I am on what's happening with Amazon. But right now it only looks like a mail order model, and that might take off as patients get more used to receiving that. But we do know that we do have mail order already established within the profession, and that is a model. And some places, some health plans mandated. So about 20% of the nation's patients are under a mandatory mail order model, which is being lifted slowly in some states. So at this point, I don't see anything exciting yet happening, but maybe they're cooking up something which I don't know. Can you expand a little bit on the role of pharmacists in digital health? Absolutely. And I think we're already seeing telehealth, take on, we did that during the pandemic. We saw telehealth coming up. Now, in terms of, providing clinical services is easier over telehealth. Telehealth, of course, is difficult when you're trying to get the product to the patient. That's where we depend on mail order. We were talking to Walgreens and other companies, and they are thinking about it and mulling over it, and where their Walgreens is creating the all-in-one where patients walk into a pharmacy and they're able to get things. But if the ideal model would be if patients are shipped the drugs, and then we have telehealth to provide those clinical services where the physician is only looking at their standard of care in terms of the diagnosis and the prescribing, and the pharmacist working with adjusting meds, the whole end of clinical services, whole gamut, as well as providing monitoring and check-ins, which are absolutely essential. One of the things I forgot to mention is in our survey of 1,000 patients, that's how many patients we surveyed, every single one of them, 100% said they want someone from the healthcare system to check on them periodically. This is new. They want to be monitored, right? So that's what's happening there. And we have a primary care physician shortage. Pharmacists can definitely fill in that gap to monitor patients periodically over telehealth, work with them, side effects, adjust meds, under the ubri of the physician nonetheless, but work on that and be paid incident to or be paid separately for services. So I do see a big role for pharmacists in digital health. What is your opinion on pharmacy platforms like Aspen Health? Can you clarify what the thing is going on with Aspen Health? Perhaps this is something I'm completely unaware about. Okay, as I wait for the response. Go ahead.
Yeah, yes. So Aspen Health is it's an Uber-like app that you can go in and do medication therapy management services in it.
Okay.
And I have my own opinions on it, but I'm just interested in what you think a piecemeal gig-like approach to pharmacy services would be.
And that's a good question. I might have to mull over that a little bit, but I think if something like that happens where, like Uber has a whole set of services, if you have a whole set of services where you can even do a cafeteria style and you pick the services that pharmacists provide. But the only issue with when you pick services piecemeal is the payment structure again gets complicated. We saw that with outcomes where you have to document for every single thing. And we need to move away from having to document for our services and practice at a standard of care model where it's time related or based on a fee schedule already set up. So if it means that we have to document each service and then pay for it, I would not be for that. But if it says you get paid this, particular per time and service, then we just use that model. I think that would work.
So what Aspen does is, based upon my limited understanding, is that they essentially work with providers to contract, and then they actually have pharmacists sign up to their app, and the pharmacists get paid a portion of the money, and then Aspen takes a piece of the cut.
Okay. And I think that might work if patients are also engaged in the model. And I think that has been a big issue, but I probably need to read up more instead of just talking out through my hat. Thank you. Okay, can you share some suggestions for changing pharmacy education so that we better prepare our students to enter this crazy system? Absolutely. And thank you for the question, Catherine. This is actually, it's part of another talk I do, the pharmacy education angle, which is it's impacting us because we already know about the curricular bloat. We keep adding topics, and these are all necessary topics: digital health, DEI. These are all topics we keep adding to the curriculum, but we never take anything away. And we really need to figure out as a profession, and I know AACP is making a very valiant effort on this, is what is it that we want to provide as pharmacists? We cannot be all things to all people. If we're having specialist pharmacists, we go that way. We really need to know what we want to be when we grow up. We are literally doing everything for everyone, and we are overloading our students, and they're getting burnt out. And pharmacists out there are getting burnt out because they are not practicing at the highest function of their license. So there is just too much, and we need to have some honest conversations. And I think the survey we did came out of one of these conversations at AACP, where we said we are wonderful as a profession at talking to ourselves and patting ourselves on the back on all the amazing things we can do as pharmacists. And it's true that we can do it, but we are not telling the outside world, and they don't know. I mean, even in our recent survey, we see physicians who are like, oh yeah, but pharmacists should dispense and they can counsel, but I don't know about collaborative practice because, I think pharmacists don't know enough. And we were just we had heartburn because we didn't use software on purpose. We went through every single comment, and we were four of us, we're all pharmacists. We were just severe heartburn looking at it, saying, in spite of IPE, in spite of collaborative practice models existing, we do have these these notions. And we do need to rise as a profession and definitely educate everyone. So I think it's kind of all interlinked, because we continue to want to prove our worth. And so we keep adding things in the curriculum saying, oh yeah, pharmacists should be doing PA and pharmacists should be doing this. And we keep adding that. And our students are so overwhelmed. And then we wonder why their progression is slower, and why our NAPLEX rates are lower, and why, our pharmacists are burning out. We need to, cut this up and stop some things right at the origin. And I'm not saying I have the answers. Honestly, no. I would start my own consulting company if I did, or totally, write papers on it. But I think we need to look at it. I'm looking at it like a Kaizen model, like a almost like a design model, where we piece up this into small pieces and say, what can we address it? A, B, C, D, E, F, and start looking at improving every part of this model. And within education, we need to take a honest look at what is it that we want to teach our students. I'm not sure I have the answer, but we need to start looking at small pieces and have our pharm-sci and practice and SAS faculty come together and say, can we teach this in a, in a like a focus group kind of a trend model where everyone is a tandem model where we can teach things together and have the students take away applications of how to improve, how to change careers, how to, really go out there and be movers and shakers and not be satisfied in just filling prescriptions or even counseling, but really shake up the profession. And every time I have a question, and I know many of you may share this, I have a question I am simply stumped about. The people I go to are our students. They have the most creative, innovative solutions, whether it's creating infographic for some education or coming up with, my entire one of my research streams on prescription labeling. We redesigned prescription labels, tested it, improved functional health literacy. That entire stream was based on one question asked by one of my API students who said, why do we not have indication on the label? And I said, well, Ken, let's go find out. And that started a whole stream where we looked at indications, looked at things, and we know it was like a 7-year project. So I think our students are amazing. They're trailblazers. They are innovative. We need to reach out to them. So I really would call on AACP to include students in some of their deliberations. I would look at within our colleges of pharmacy and have students play very active parts because they come up with solutions we haven't even dreamed about. They are the future, and this is a profession for them. All we are doing is tooling them.
Thank you so much for that thoughtful answer. Just real quickly, before you move on to Dr. Salgado's question, if you wouldn't mind throwing up the CE code on the screen for those who have a meeting at 1 or have to get to the next class, that would be great. Thanks.
Okay, thanks. Thanks, Madhu.
Thank you.
What specific services do you think we should focus on implementing, expanding in community pharmacy that the patients would recognize value and seek for them to be provided in that setting? So we're looking at patients now, right? And, we found some things in our survey which said, and ultimately be happy to pay out of pocket. Okay. So, we found that patients do want to be monitored, right? They want someone checking up. And I think this is checking on them periodically. I think this is something we could totally do because we know that most of our chronic conditions are treated by meds and we should be the interface for that. And, even if it's say they're getting pharmacy, we are not changing the profession overnight. If they're getting their prescriptions at a pharmacy, if the pharmacist can periodically monitor them and work with them, and of course, we paid for it because that has to be aligned. And we continue following the patient. And this is where our accountable care model, the one I presented, the value-based payment, where if the patient is part of that equation and accepts incentives to continue, adhering and maintaining their numbers, right? It is possible for patients to be our advocates and say, and those are our best advocates, right? We know that that lobby is very powerful. If the patients continue to adhere, we have pharma industry, which is on our, also on our side, because that helps them with their sales. So where we shift the power from the PBMs, and I'm not saying PBMs are all evil. I mean, I'm really, I'm being realistic, but I'm saying if the power shifts where we say, we have a little bit more say on the meds that the patients are getting, because right now it is decided by someone else. But if we can get that system to say, we monitor the patients, we're working with the physicians. If there is need for referral, of course we refer back, but otherwise we continue to monitor the patients, and patients see us as part of the primary care equation. I think that would really work, but it has to be tested. I mean, I passionately believe in that accountable care model. I've talked to 6 health plans in California. They all love the idea until I come to the risk reward, and they're like, oh, we don't know if this will be okay. So we are getting ready to test it with some commercial models. But at this point, and California is highly regulated. I'm actually looking at other states also to test the model where there is more of, a possibility of discussion with health plans. But that is something I would definitely like to test. Professional identity. Absolutely. Thank you for that. And I guess that's what I was trying to say. We need professional identity. It's a discussion we've begun at AACP and APHA, and we need to follow up on that. And once again, not get bogged down by saying, okay, we need professional identity formation. Now it has to be in the standards, and now we need to assess it, and now we need to prove it. And I think some of the things we do in academia, which are wonderful, we do wonderful things, but I think we get bogged down by just having to continually assess it and prove it and check those boxes. And some of our energy is spent in just doing that instead of just focusing on saying, let's see how this works for our students. And of course we need assessment. Of course we need that it works. And I'm an assessment dean, so I can't say no, assessment is not useful. But I think we need to reduce the stress on only assessment and see what really works. And if it's working, let's standardize it. And I think that's something we really need to work with professional identity. It shouldn't be only to meet the standards. It should be really to shake up the profession. Any other questions? These are all great questions, and I'm so excited to answer, but I know your time is up and some of you have other things, other places to go to. So I really appreciate your attention and your questions and comments. And I will look into Aspen Health model. Thank you, Dr. Holford. And thanks again, Dr. Salgado, for inviting me, and for all of you being here. And thanks, Madeline. And have a wonderful day, all of you.
Thank you so much, Dr. Law, for being here. We really appreciate it. And if you wouldn't mind sending me your slides so I can share them with folks who are here, I would love that. Okay. Thank you so much, everyone, for being here. Have a good rest of your day.